Hit the subscribe button or visit us at auau.auanet.org.
Good morning and welcome to Diagnosis and Management of Localized, Locally Advanced, and Advanced Kidney Cancer, presented by the AUA. We strive to offer outstanding educational courses and greatly appreciate your evaluations and general feedback so we can continuously improve our programs. We thank you for joining us. Before we get started, I'd like to go over a few items so you know how to participate in today's event. First, I'd like to extend a special thank you to our course director, W. Marston Linehan, for planning an excellent educational course. We thank you for your dedication and commitment to urologic education. Thank you as well to our faculty for their time, talent, and expertise for today's program. The AUA is accredited by the ACCME and designates these other activities, live virtual activities, and enduring materials for a maximum of 2 AMA PRA Category 1 credits. Evaluations are very important to us. Course evaluations and CME credit will be administered electronically on the AUA 2021 site immediately following the live program today. As the AUA continues to develop virtual education that meets your needs, we welcome your feedback regarding both the content and format of this activity. Please visit AUA2021.org to complete your evaluations and credit claim. All persons in a position to control the content of an AUA educational activity are required to disclose any relevant financial relationships with any commercial interest. Please visit AUA2021.org to view faculty, education council, and COI review workgroup disclosures. The American Urological Association would like to thank AstraZeneca, Bristol Myers Squibb, and Merck for their generous support of this educational program. This activity is meant to be educational in nature and in some instances reflects the opinions of the presenters. The information does not guarantee accuracy of claims submitted. Please verify the accuracy of individual medical claims submitted and please follow individual insurers' rules. I will now turn the activity over to our course director, Dr. Linehan. W. Marston Linehan is a chief of the Urologic Oncology Branch at the National Cancer Institute, National Institutes of Health, Bethesda, Maryland. After completing his internship, residency, and fellowship training at Duke University Medical Center, he began his career at the National Cancer Institute in 1982 with positions as senior investigator and urologic in charge at NCI. It's my pleasure to turn it over to Dr. Linehan.
Thank you very much. Good morning, everyone, and welcome. So I'd now like to introduce our faculty. And we have a really great faculty. I'm happy to introduce Dr. Mark Ball, Associate Program Director of the Urologic Oncology Fellowship, Senior Staff Surgeon at the National Cancer Institute, National Institutes of Health. He's board certified, of course, at American Board of Urology. Very happy to have Dr. David Mcdermott with us. Dr. Mcdermott is Chief of Medical Oncology at Beth Israel Deaconess Medical Center in Boston. He's Director of the Cutaneous and Immuno-Oncology Programs, Co-Director of the BIDMC Cancer Center Immunotherapy Institute. He's leader of the Dana-Farber Harvard Cancer Center Kidney Cancer Program, and he is co-investigator for the National Cancer Institute Specialized Program of Research Excellence SPORE grant, one of the great prostate cancer programs in the country, focusing on kidney cancer. Dr. Rama Prasad Srinivasan is an investigator and head of the molecular cancer section in the Urologic Oncology Branch at the National Cancer Institute. graduated from Bangalore Medical College, India, obtaining his MD/BS degrees. Dr. Srinivasan subsequently pursued a graduate study at MD Anderson in Texas, where he got his PhD. He came to NCI in 1999 after completing his internal medicine residency training at the University of Texas Health Science Center to pursue a fellowship in medical oncology, and is now, as I mentioned, investigator and head of the molecular cancer sections. So we will now get started with our presentations. So I'm going to talk briefly about the genetic basis of kidney cancer and the implications for us as urologic surgeons in diagnosis and management of kidney cancer. Now, when we started our work, kidney cancer was a single disease. We managed all patients the same, gave the same agents, the same therapies, none of which worked, did the same surgeries for all of our patients. We now know that kidney cancer is not kidney cancer. It's a number of different types of cancer that just happen to occur in this organ. Different histologies, different clinical course, responding differently to therapy, and as we'll show you, caused by different genes. We now know of 18 different genes that cause kidney cancer. Now, why are we interested in this? One, as urologic surgeons, it'll help us manage these patients. Do we do active surveillance or do we do surgery? What kind of surgery do we do? Robotic versus open, does that make a difference? Turns out it does. Enucleation, should we just enucleate them all? Should we do wide margins on them all? A lot of it depends on the histology and the gene. What types of therapy should we give these patients? And you'll hear two wonderful talks about therapy. You'll really learn a lot. I know I will. Should we use agents targeting the VEGF, VHL, HIF, VEGF pathway? Should we use agents targeting the MET pathway? Or the so-called IO drugs targeting PD-1, PD-L1, CTLA-4? Well, we'll hear a lot about that this morning. Well, what do we know about the genetics of kidney cancer? How do we figure that out? What do we know? What we know today, most of what we know today, we've learned from studying the inherited forms of kidney cancer. And we're going to talk about 4 briefly. We're going to talk about clear cell kidney cancer, type 1 papillary, type 2 papillary, and then TFE3 kidney cancer, just to illustrate how we manage different types of kidney cancer. So when we started back in the 80s, we showed that there was loss of a segment, you can see on the left, of chromosome 3 in tumors from patients with clear cell kidney cancer. Well, we wanted to find the gene. This work suggested to us that there was a disease gene on chromosome 3 for clear cell kidney cancer. But this was 13, 14 years before the human genome was even sequenced. We had no map. So what we did was we switched to studying families with kidney cancer, and we started with the most well-known one called von Hippel-Lindau, VHL, in which patients are at risk to develop tumors in a number of organs, including, of course, the kidneys, where they're at risk to develop bilateral, multifocal, clear cell kidney cancer. These are always clear cell. These patients, you'll see, get tumors and cysts in their kidneys. And over the years, we've managed a large number of patients. Actually, we're now up to 1,100 patients from over 400 families, and have performed surgery on many, many of those patients over the years. And we've developed an approach to management. And that is patients with these small clear cell kidney tumors, we recommend active surveillance until the largest tumor reaches 3 centimeters, at which time we recommend surgical intervention. Now, with this approach, over the last 34 years, even though a number of our patients have either come to us with metastatic disease or developed metastatic disease, to date, as of May 22nd, 2021, we have not yet had a single patient develop metastatic disease when managed in this fashion with VHL clear cell kidney cancer. Now, most of our patients, almost all of them, you'll hear a lot about this from Dr. Ball, we manage now, of course, with surgical therapy. So this is how we manage those. We do an enucleation. I just want to show you this one brief video. So this is a patient with VHL clear cell kidney cancer. As you can see, we're enucleating this. We're coming right around the tumor, not leaving much of a margin. There's a little pseudocapsule. We're coming around that. We've taken out as many as 93 tumors from a single individual. It'd be hard if we went wide, of course, to have any kidney left. But that's how we manage those. So that's clear cell with VHL gene mutation. So how did we find the gene? Well, we brought patients here. This is the National Institute of Health, this 300-acre campus. What you're looking at right there is the hospital, the NIH hospital, called the clinical center, and the urologic surgery program, of course, is right in the middle there. We brought patients. We did a linkage analysis. We localized the VHL gene to chromosome 3, and then we identified that gene in the spring of 1993. This is the VHL gene. It's what we call a 3-exon gene, and we're looking for mutations that segregate with the disease, and that, of course, is what we find. We have found VHL mutation in every single one of our families. So we're thrilled about that. That's how you make the diagnosis of this disease. We've now got a blood test. All over the world, people use that test. We're thrilled about that. However, we wanted to know, was this the gene we look for so long? Is this the gene for the sporadic, non-hereditary form of clear cell kidney cancer? And the answer to that is yes, it is. We find mutation of the gene or methylation, another way to inactivate the gene, in over 90% of tumors from patients with clear cell kidney cancer. Okay, we got the gene. Now, well, we want to figure out how it works. We want to be able to develop therapies. This was a totally new gene. We found it, completely novel. We had no idea how this worked. So we started looking at this, and we and others have shown that the VHL protein, the VHL gene, forms a complex, and that complex targets another group of proteins called hypoxia-inducible factor, HIF, for ubiquitin-mediated degradation. And what happens here is this is oxygen sensitive. So when there's normal oxygen in the cell, the complex targets HIF and degrades it. However, when the cell is short of oxygen, hypoxia, the complex cannot target and degrade, and HIF accumulates. Well, HIF is a transcription factor that drives other genes like vascular endothelial growth factor, VEGF, or GLUT1, which brings sugar into the cell, or PDGF, which drives the cell. And that's what our cancer does. Now, this complex, and that VHL is an oxygen sensor. The people who did this were awarded the Nobel Prize, Bill Kaelin, Peter Ratcliffe, and Greg Semenza, for showing that VHL HIF is an oxygen sensor for the cell. Now, for us, we're very interested in knowing how this leads to kidney cancer. And so what we've shown is that when the VHL gene is mutated, is damaged, either on the right side, what's called the alpha domain, you can't bind the complex, or on the other side, left side, the beta domain, you can't bind to HIF for degradation. Either way, HIF accumulates. And that's what happens in clear cell kidney cancer. That's all it is. It's very simple. It's as though the cell thinks it's short of breath. It needs more blood vessels. It needs to grow. It needs to bring in sugar to grow. And that's what cancer is. Now, understanding this pathway is what provided the foundation for the development and FDA approval of 9 targeted drugs that target the VHL pathway for patients with advanced kidney cancer, as you can see here. Now, you see remarkable responses, and it just makes my knees weak really to think about it. However, we want to do better. So we and others, our group and the Kalin group, showed that HIF-2 is a critical part of the VHL HIF pathway. And that led to the development of small molecules, a drug now called belzutifan, which targets the HIF-2 pathway. And you'll hear some remarkable data on how this is being used now as a very selective drug for use in patients with von Hippel-Lindau VHL, as well as patients with advanced clear cell kidney cancer. This shows it being used in patients with VHL, as well as advanced kidney cancer. Now, what are possible approaches, though, for people who don't have clear cell kidney cancer, like type 1 papillary and type 2 papillary? And I'll tell you right now, those are 2 very different diseases. And the third one we'll talk about is called TFE3 kidney cancer, which is what you see a lot in children and young adults. So we'll talk about that. But the first one is type 1 papillary kidney cancer. When we started our work, we had no idea what the gene or genes was associated with type 1 papillary kidney cancer. So we discovered like a hereditary papillary kidney cancer in the Journal of Urology in the 90s. We called hereditary papillary renal carcinoma, or HPRC, and we found, and these patients get bilateral, multifocal type 1 papillary kidney cancer. Now, that's very similar to your patients that come without hereditary kidney cancer, much more common, that get bilateral multifocal type 1 papillary kidney cancer. Now, this is what that looks like. You can see these multiple tumors in these patients' kidneys. And on the right, you see the type 1 papillary. Now, how do we manage these people surgically? They have type 1 papillary kidney cancer. What we do is the same thing, the same way we manage the clear cell kidney cancers. We wait till the largest tumor reaches 3 centimeters, at which time we recommend surgical intervention. So we recommend surgery when the tumors reach 3 or larger. And again, when we operate, we've taken out as many as 60 tumors in these patients' kidneys. And these, we do nephron sparing surgery, and we do enucleation here, just like the clear cell that I showed you a minute ago. Now, we studied these families at NIH, and we identified MET, M-E-T, as the gene for the familial form of type 1 papillary kidney cancer. MET is the receptor, the cell surface receptor, for a growth factor called hepatocyte growth factor, or HGF. And what we find is mutations in what's called the tyrosine kinase domain of this gene you can see here in tumors and in the germline of those patients with hereditary papillary renal carcinoma. Now, that then led us, and you'll hear from Dr. Srinivasan about this, that then led us to do a trial. Dr. Srinivasan ran a trial, multi-center trial, using an agent called ferretinib, which targets VEGF and MET. And Ferretinib, when you think about Ferretinib, you can just think cabozantinib, almost identical drug produced by the same company. They went forward with that drug. So you can think of cabozantinib targeting the MET pathway. So that's type 1 papillary kidney cancer. We also find mutations, like I showed you in the hereditary, in sporadic, not as many, but we find those in sporadic type 1 papillary kidney cancer, and amplification, increased copy number in up to 81%. So MET is very important for hereditary, but also your patients with sporadic papillary kidney cancer. Now, this is another type of familial form of kidney cancer we described in the 90s, but a very aggressive form of type 2 papillary kidney cancer, we now know called hereditary leiomyomatosis and renal cell cancer, HLRCC. And those patients can get skin bumps, which are cutaneous leiomyomas. And a big tip-off for you is this, is the women get uterine leiomyomas, and they occur early, late teenage years, early 20s. And a very aggressive form of papillary kidney cancer. This is the first patient known with this. I operated on this patient in May of '89, and she went on to die, this 18-year-old, 7 months later of metastatic kidney cancer. Her mother died 14 months after that. And over the years, we've lost 8 members of this family with aggressive kidney cancer. This is a 32-year-old we saw with a very small tumor, a 1/2 centimeter tumor. His father died at age 35 of metastatic kidney cancer. When he presented with that 1/2 centimeter tumor, he had a 2 centimeter node in the hilum of the kidney, which was positive for type 2 papillary kidney cancer. In these families, we see these tumors in 10-year-olds. We see them in 77-year-olds. This is a 24-year-old who presented with 2 tumors inside a cyst. We went way wide on this, went wide, no enucleation, wide margins. We found tumor in the cyst, but also very much infiltrating the normal renal parenchyma. So you have to go wide on these. Also, we have to watch these people every year. This is a 43-year-old who came, didn't have anything in her kidneys, was going to be followed on the outside. 3 years later, they did imaging. They read it as normal, but there was this little lesion there, 8 millimeters. She didn't have imaging again for 4 years. We got a call from doctors at a hospital in Baltimore. They said, "Hey, we got one of yours over here." It's a 50-year-old. She now was 50. She had this big tumor, 10 of 59 nodes. We lost her 2.5 years later with metastatic disease. It's important that they're have active surveillance every year. Surgical management should not be delayed in these patients. We do not wait for 3 centimeters. We do these open and we go wide surgical margins and open on these. The gene for this is on chromosome 1. It's a gene for a Krebs cycle enzyme called fumarate hydratase. When FH that is knocked out, it poisons prolyl hydroxylase, and HIF accumulates, like we showed a minute ago, but this is not due to VHL. These people these tumors make a lot of VEGF, and with Srinivasan, we developed an approach to target these patients with bevacizumab and erlotinib, and saw really dramatic responses you'll hear about in a minute from Dr. Srinivasan. So the last thing I'll tell you about is this patient, this disorder. Just another type of kidney cancer. And this is the first patient known with this, a young woman I operated on in 1987. I took out her left kidney. She still died 9 months later of metastatic disease. She was 21, came from Ohio. She had papillary kidney cancer. We'd never seen this type of cancer before. We grew the cells in the lab, and we found that it had a translocation from the first chromosome to the X chromosome. And we found out a couple of years later, in 1996 actually, that what was happening was a gene on chromosome 1 was translocating and activating a gene on the X chromosome called TFE3. So this was really the first report of TFE3 kidney cancer. So when you see kidney cancer in young patients, think of TFE3 kidney cancer. And this is the kind of histology you have. It's a aggressive type of papillary kidney cancer, and your pathologist will stain it for TFE3. You can see it's very hot here, very bright. But what you want them to do for you, if they have one undifferentiated, they're not sure what it is, ask them to do a FISH test, and that will make the diagnosis. Now, TFE3 kidney cancer is 42% of kidney cancer in children and young adults. Also, this 23-year-old we saw, law student, we saw had a 2-centimeter mass in her left kidney. You can see here, she already had positive nodes. So we do not do active surveillance with TFE3 kidney cancer. When we detect tumors, we operate and we go wide. This is a 12-year-old. Just if you see a kidney cancer in children and young adults, think of TFE3 kidney cancer. So what I've shown you is that kidney cancer is not simply kidney cancer, made up of a number of different types of cancer, different histologies, responding differently to therapy, and caused by different genes. And it's our hope that understanding the genes that cause kidney cancer will make you and me, you and us, will make us better surgeons. We'll know when to do active surveillance, when to operate. We'll know what kind of surgery to do. Do we do a nucleation? Do we go wide? And also, we'll provide the foundation for the development of effective forms of therapy. I've already shown you 2 situations. We're targeting the VHL pathway and the MET pathway. With small renal tumors, we can see dramatic effect. And we're going to hear from Dr. Mcdermott and Dr. Srinivasan some very exciting data about treating patients with advanced disease. Next, I want to introduce Dr. Mark Ball, who's going to talk about surgical management of patients with kidney cancer.
All right, good morning. Thank you very much to the AUA for the opportunity to speak this morning for this course. I'm going to be discussing decision-making during complex partial nephrectomy, and this is going to be a guidelines and an evidence-based approach. No disclosures. And so really a couple of different things to discuss. One is when to perform a partial nephrectomy. What do the guidelines suggest when we should be doing partial? We know that historically, partial nephrectomy has been underutilized. Perhaps now we're at the point, and at least in academic institutions, it may be overutilized. So when is the ideal time to perform a partial nephrectomy? And then really the bulk of the talk is decision-making during partial nephrectomy. So I really break that down along 4 axes: when to do open versus robotic, transperitoneal versus retroperitoneal, enucleation versus wide excision, and on-clamp versus off-clamp. Certainly a large component of that decision-making here at the NCI and elsewhere factors in what Dr. Linehan just discussed. Really knowing the genes can really drive this decision-making. But I'm also going to discuss other preoperative and intraoperative factors that may influence that decision. So choosing candidates for partial nephrectomy is a bit of a Goldilocks approach. There are some tumors that are too cold, some situations too hot, and then some that are just right. Now, as I go through this, I want to remind you this is an interactive session. If there are questions that come up, you don't have to wait until the end. Please type them in the chat and we can answer those. So what is a situation that's too cold? Well, that may be a case that's more appropriate for active surveillance. So according to the AUA guidelines, for patients with small renal masses, especially those less than 2 centimeters, active surveillance is an option for initial management. Now, this does not apply to some of the situations that Dr. Linehan discussed, like in HLRCC or SDH deficient kidney cancer. But for a patient without a family history, a sporadic patient, this can be a good initial management option. Physicians should also prioritize active surveillance when the anticipated risk of intervention or competing risk of death outweigh the potential oncologic benefit of active treatment. So in other words, for patients who have high other cause morbidity and mortality, any type of treatment for their small renal mass may not be warranted. On the other end of the spectrum, some situations are too hot, and those patients may be better served with radical nephrectomy. The AUA guidelines again suggest that radical nephrectomy should be considered for patients where there is an increased oncologic potential. And what does that mean? Well, it's preferred in all of the following. For patients, if all of the following are criteria met. If a patient has a high tumor complexity, and partial nephrectomy would be challenging, even in experienced hands. We know that as technically there are many things that we can do, but they may not always be the best oncologic option. For patients that have no pre-existing CKD, no proteinuria, and who have normal contralateral kidney function, where a baseline GFR would likely be greater than 45, radical nephrectomy is fine to perform for these patients. So finally, partial nephrectomy is that just right in the middle situation where the anticipated oncologic benefit of intervention outweighs the risk of treatment and the competing risk of death, and their physician should pursue treatment. So now going to our sort of 4 axes of decision-making during partial nephrectomy. We'll start with the first one, open versus robotic. And in speaking with colleagues, this is probably the question that comes up most. How would you approach this? How should I do this? And I think that the number one sort of driver of this really should be surgeon experience and comfort. If a surgeon thinks that in their hands an open surgery is safer, or they are more comfortable dealing with scenarios B, C, and D that may happen, by all means, open surgery is fine. On the flip side, if a surgeon is more comfortable with robotic surgery, then that should play a big role in the decision making. As we see on the graph on the right, this shows the proportion of partial nephrectomies performed open in the light box and robotically in the dark shaded areas. And each year, more and more partial nephrectomies are performed robotically. This means that current trainees will likely have more experience with minimally invasive and robotic surgery than open. So in the future, in the present and in the future, I think that more and more complex surgeries will be tackled robotically. Other reasons why open surgery may be preferred: the need for cold ischemia. If there is a high complexity tumor in a patient with CKD, they may be better served with cold ischemia. That is certainly easier to accomplish during open surgery. As we heard from Dr. Linehan, for certain histologies and certain genetic syndromes like HLRCC or SCH deficient tumors, those are better approached using an open approach because of the risk of tumor going into the renal parenchyma and of tumor spillage. And finally, for patients with prior renal surgery, historically open surgery has been emphasized, although we have some data to support robotics in that population. So at the bottom, what do the AUA guidelines say? That in patients undergoing surgical excision of a renal mass, a minimally invasive approach should be considered when it would not compromise oncologic, functional, or perioperative outcomes. When we do robotic surgery, the Da Vinci Xi robot is the one that is probably most used today. So we can see our port placement for left-sided surgeries here, 4 ports along the lateral edge of the rectus muscle. I do prefer 2 assistant ports at the umbilicus and just above. That is mirrored for right-sided cases with the addition of a liver retractor, especially for upper pole tumors. For open surgery, the mini flank incision that was described by Dr. Russo and others is really utilized, can be utilized for most cases, and that is an incision between the 10th and 11th rib. The 11th rib is spared, and this is a lower morbidity incision than what was historically used. And if you're interested in learning more about this approach, our group here at the NCI has a video on the AUA core curriculum. It shows all the steps in performing a mini flank incision. So as I said, for redo surgery, traditionally reoperative surgery was used. Open surgery was used in the reoperative setting. But here and elsewhere, we've begun approaching more and more complex kidney surgeries robotically, including second, third, and even fourth time partial nephrectomies, even after previous open surgeries. We can see why open surgery was traditionally used. Sometimes there is a lot of fibrosis on the inside. You can see on the X-ray on the left, all of the previous clips used in bilateral partial nephrectomies. Each of these clips has fibrotic reaction around it, making the planes distorted. Sometimes no planes exist whatsoever. On the right-sided image, a patient with a prior midline and multiple levels of flank incisions and thoracoabdominal incisions. When we looked at data from our institution, though, Sandeep Guram, one of our senior fellows, recently put this together for Journal of Urology. We found that in 192 reoperative partial nephrectomies performed here at the NCI, that not only was robotic surgery as good, as safe as open surgery, it actually may have had some benefit. There were fewer complications and less blood loss for robotic cases. Obviously, selection bias may play a role here, but robotic surgery can be safely utilized in experienced hands. Some considerations for robotic redo surgery: the anatomy can be distorted, so we always place a ureteral catheter to identify the ureter. Gerotis fascia should be preserved. It's a great natural barrier to prevent adhesions between the kidney and the liver, the kidney, and the small and large bowels. So we open it in a clamshell fashion and then suture it closed at the end. We don't use clips because those clips can promote more fibrosis. Ultrasound early and often in these cases, and not just to identify tumors, but they can also be used to identify the ureter, especially if that ureteral catheter is in place, and the renal hilum. Again, the anatomy can be distorted, and it's not always where you expect these structures to be. And finally, the hilum should be approached cautiously if it's been previously dissected. You can't always create a plane between the renal artery and vein a second time. So sometimes the hilum, if it needs to be clamped in block. And for exophytic tumors, we often will not dissect the hilum a second time. So what does the literature say? In a meta-analysis of open versus robotic partial nephrectomy of over 60,000 patients, robotic surgery had less blood loss, transfusions than open surgery, albeit with a longer operative time. It was associated with fewer postoperative complications, a lower readmission rate, shorter length of stay, and interestingly, less decline in eGFR. Moving on then to transperitoneal versus retroperitoneal surgery. When is the ideal time to perform each? I would say that for most people, transperitoneal is the default option. It's the most familiar anatomy, and there's more working space. In my practice, that is certainly still the case, but retroperitoneal surgery is an important tool to have in the armamentarium. So when is it good? It's good for posterior tumors, because you can access them very quickly. You can see the base of the tumor to perform a better renorrhaphy, and you can access the renal hilum pretty quickly. But that comes at the cost of less familiar anatomy, especially in the first few cases. There is a little bit of a learning curve, and there is less working space. So this diagram shows our port placement using the Da Vinci Xi for retroperitoneal surgery. It's centered around just 1 centimeter above the ASIS, and we form a line with 4 ports spaced 1 handbreadth apart, going towards the umbilicus medially. The ideal retroperitoneal candidate in terms of tumor location is in the posterior aspect of the kidney, so posterior to the renal hilum, and really this is better for mid in upper pole tumors than lower pole. When you're dealing with a lower pole tumor, sometimes it's too close to the instruments and the camera to be facile with the decreased working space in the retroperitoneal approach. The literature here is not as robust as the open versus robotic literature, but in 7 studies, all retrospective, of just over 1,000 patients, we found that retroperitoneal surgery was associated with less operative time, less EBL, and less length of stay. Again, obviously subject to some selection bias. Enucleation versus wide excision. We already heard from Dr. Linehan. Again, there are some hereditary syndromes that we routinely use enucleation, such as VHL, hereditary papillary renal cell carcinoma, Birt-Hogg-Dubé, and others where we do wide excision, like HLRCC and SDH. But what about for sporadic patients? We can use both enucleation and wide excision under these circumstances. The benefits of tumor enucleation are you can preserve more parenchyma. You can see the tumor, so especially for complex tumors where it's abutting hilar vessels or the collecting system, there's no guessing the depth. You can follow the pseudocapsule all the way around and you can avoid those structures or purposely take them as a margin. You can, like I said, avoid collecting system entry completely. And even off clamp, if you are in this enucleation plane, patients have less blood loss. So candidates for this are patients with some forms of familial kidney cancer, for patients with multifocal disease, or with severe chronic kidney disease. For the typical unifocal sporadic patient, enucleation is not necessary. If you're dealing with one tumor and want to ensure a negative margin, it's fine to do a standard or even wide excision partial nephrectomy. What do the guidelines say? For patients undergoing partial nephrectomy, a negative surgical margin should be prioritized, and the extended parenchyma should be determined by the surgeon, taking into account the clinical situation, tumor characteristics, including growth pattern, and the interface with normal tissue. And again, and this goes back to one of those questions at the beginning, tumor enucleation should be considered in patients with familial, multifocal, or severe CKD to optimize parenchymal mass preservation. In a study looking at functional comparison of enucleation versus standard partial nephrectomy, you can see that warm ischemia and zero ischemia were used in 51 and 49% of cases for tumor enucleation. And for standard partial nephrectomy, warm ischemia and cold ischemia were used in 72 and 28% of cases, respectively, meaning that you can perform off clamp. Doing tumor enucleation also gives you ability to perform these cases off clamp. Positive margins were slightly increased in the tumor enucleation group at 8.5% versus 4.8% in the standard partial nephrectomy group, but this was not statistically significant. The final axis here, on clamp versus off clamp. So indications for off clamp nephrectomy include multiple tumors not amenable to extended warm ischemia time, patients with a solitary kidney, existing CKD, previous kidney surgery, especially when the hilum is scarred, and in planning for future kidney surgeries. For instance, for patients with hereditary kidney cancer, where you know that they will need future partial nephrectomies or maybe even a radical nephrectomy in the future. Performing the current case off clamp, not dissecting the hilum, may prevent scarring. So you save the hilar dissection for when you need it. And then, as I mentioned in the last section, off clamp, partial nephrectomy, and enucleation kind of go together. So if you're planning for one, it's probably best to consider the other. So some considerations for off clamp partial nephrectomy in terms of blood loss. There is more blood loss with enucleation than wide resection. So I always have a lap pad or a bolster in the patient for manual compression of the base of the renorrhaphy of the tumor resection defect. What does the literature say? Looking at off clamp versus on clamp, there are similar transfusion requirements, complications, and positive surgical margins. So really, I see off-clamp as a tool, again, to enable tackling multifocal tumors primarily. So putting it all together, the population of patients that we see at the NCI, we see all forms of kidney cancer, but a large percentage do have either hereditary or a non-hereditary but multifocal kidney tumors. And so the most common combination that we utilize is a robotic, off-clamp enucleation, mostly transperitoneal. And particularly that combination of robotic, off-clamp, and enucleation can maximize the preservation, renal parenchymal preservation while minimizing blood loss and complications. So let's look at a few cases. Case one, this is a woman in her 60s. She had a previous right partial nephrectomy and a previous left radical nephrectomy. So now a solitary right kidney that's been operated on before, and she has a 3 centimeter posterior renal tumor. Her creatinine is 1.6, a GFR of 35. So she has CKD. So what's the decision-making process here? We chose a robotic retroperitoneal enucleation off-clamp. Retroperitoneal because of the tumor location, and that combination of robotic off-clamp enucleation to spare renal parenchyma and also avoid large EBL intraoperatively. So here is a video of that case. We can see the tumor on the ultrasound, and then just like in the video that Dr. Linehan showed, with enucleation, we really get very close to the tumor, and as we're going around the base of the tumor, we're really brushing away all of the normal renal parenchyma. And you can see this is off clamp, not much bleeding when you really stay in this enucleation plane. Sometimes there are perforating vessels here that we can push off or use point electrocautery to control. But carefully pushing off all that normal renal parenchyma, we have a robust pseudocapsule here, no concern oncologically, but at the same time, maximal preservation of renal parenchyma. And so in this case, 0 warm ischemia, 0 minutes of warm ischemia, EBL was 100 cc's. This was a Furman grade 2 clear cell RCC with negative margins, and we were able to preserve her renal function. On discharge, GFR was actually a little higher, probably an artifact of being well hydrated after surgery, but certainly no decline in renal function. Case number 2, this is a 31-year-old woman. She already had a left partial nephrectomy. Interestingly, germline panel is negative. This is not a hereditary kidney case. This was just a bilateral renal tumor case, bilateral multifocal case. And this is a patient with excellent renal function. GFR was 100, a central 3 centimeter tumor, may be a candidate for a radical nephrectomy, but she's 31. So we decided to perform a partial nephrectomy in this case. And our decision-making, we elected to do robotic transperitoneal enucleation, but because of the depth of the tumor, we did decide to clamp the renal hilum. So for a completely endophytic tumor, if we're trying to enucleate, we have to we can't just excise all the normal renal parenchyma overlying the tumor. So this is a paper that Amir Labashi, one of our former fellows, recently wrote up. It was published just last month in Urology, looking at our technique for resecting completely endophytic renal tumors. And what we do is we develop flaps in the renal capsule and to expose the underlying tumor. And maybe a problem with the video on that slide, it looks like. But in this case, the warm ischemia time of 19 minutes, 55 cc EBL. Pathology was again Furman grade 2 clear cell RCC with negative margins. Again, excellent preservation of renal function with no recurrent or de novo disease, now 24 months since surgery. Last case, a 71-year-old man with bilateral renal masses and a negative genetic workup. We biopsied the right mass, which was a smaller but central renal mass that showed clear cell RCC. The left was not biopsied. And so we decided first to tackle this big left tumor. And tackling that, we decided to do a robotic transperitoneal wide excision because of the size on clamp partial nephrectomy. So just in my last couple minutes here, I'll just show you this video briefly of, you've seen enucleation. This is now a wide excision, and you can see the difference. We use ultrasound to demarcate a margin that is a centimeter, half a centimeter to a whole centimeter away from the edge of the tumor. Instead of that smooth capsule, we see this sort of more jagged normal renal parenchyma. We are on clamp, so EBL is acceptable, and we have a nice margin. This was an 8.5 centimeter chromophobe RCC with a negative margin, and we were able to preserve renal function. Tackling the other side, what we found is, I won't show the video because we're running out of time here, but we saw, you can see in the still at the bottom, this tumor is abutting the main renal vessels. So we decided to do a radical nephrectomy on the contralateral side. It was just too hot, and I'm glad we did, because this, even though it was only 3 centimeters, this was a Furman grade 3 clear cell RCC invading the renal sinus fat. So this patient, GFR after bilateral surgeries was 38, but he has no evidence of recurrent disease and is not on hemodialysis. So in conclusion, the decision to perform partial nephrectomy, we have to weigh the oncologic risks versus other competing risks of surgery. It requires the input of patient, tumor, and surgeon factors. And being facile with each of these 4 domains gives you more tools in the armamentarium. 2 to the 4th power gives you 16 surgical options when performing partial nephrectomy. So again, thank you for your time, and address any remaining questions at the end of the talk, at the end of the 4 talks. Thanks.
So our next speaker will be Dr. David Mcdermott.
Good morning, and Marcin, thank you very much for the kind invitation, and thanks to the organizers. I'm here to speak to you today about how immunotherapy fits into the treatment algorithm of patients with advanced kidney cancer. In the past, this has been a discussion mostly about the metastatic setting, but starting next week at ASCO, this is a story that's going to move into the adjuvant setting, and urologists are playing an increasingly important role in making treatment decisions because of these advances. So I hope this talk is even more relevant than normal. Here are my disclosures. And these are the folks, as Marcin mentioned, at the Dana-Farber Harvard Cancer Center Kidney Cancer Program. I'm going to be talking a lot about their work. So immunotherapy for solid tumors is actually a surgical story. Was developed in the 80s by folks like Dr. Steven Rosenberg at the National Cancer Institute Surgery Branch. You see him here on the cover of Newsweek talking about interleukin-2. And it was these deep and durable responses that his group saw with high-dose IL-2 that led to its approval, first in kidney cancer and then in melanoma. And it was this aggressive approach that honestly didn't work for most patients, but established a principle that with immune therapy, you could take a metastatic cancer and put it into remission and potentially cure patients. The scientific discoveries that were made subsequently by folks like Gordon Freeman and Dr. Hanjo, who won the Nobel Prize for his work with the PD-1 pathway, essentially allowed us to make advances beyond cytokine immunotherapy into the world of immune checkpoint blockade, agents that Dr. Freeman developed, some of the earliest agents that actually could block the interaction between PD-1 and PD-L1 and block one of the natural brakes that the immune system places on on a response to cancer and unleash its more of its full power against a variety of tumors. These drugs were quickly converted from lab discoveries to actual agents that were tested in multiple tumors. sort of changing the paradigm for kidney cancer and a variety of other cancers. This is the paper from 2015 that led to the FDA approval of PD-1 blockade with nivolumab in advanced kidney cancer. Dr. Motzer led this effort. And you can see with this talk how much progress has been made in just the last 5 years since the initial introduction of PD-1 blockade for our patients. When we sort of think about how the immune system controls cancer, or fails to control cancer, most of the patients we meet in the clinic, whether it's in the surgery suite or in the oncology clinic, are in a setting of immune escape. When you think about the 3 E's of immunoediting, most of our patients' tumors have escaped an immune response. And PD-1 blockade, essentially for most patients, brings them back to a sense closer to equilibrium, meaning the tumor shrinks. But for most patients with single agent PD-1 blockade, you don't get complete elimination of the cancer. And obviously that's the goal. That's the goal of a surgeon. That's the goal of an immunotherapist, to try to eliminate the disease. So how can we do that in kidney cancer? Well, folks have sort of relied on preclinical experiments that suggest that the addition of other targets, like for example, CTLA-4 combined with PD-1 blockade, or VEGF blockade combined with PD-1 blockade, preclinical experiments suggested that those approaches could enhance the immune response to kidney cancer, and those were brought quickly into the clinic. What have we seen over the last several years? Well, essentially the old second line therapy, PD-1, has been fused with the old first line therapy, VEGF, in a series of pivotal trials that have led to the establishment of PD-1 blockade and VEGF blockade as a standard approach for patients with metastatic disease. This is one of those seminal trials that was led by Dr. Srini and Powles that established PD-1 plus axitinib as superior to sunitinib. And there have been a variety of trials since then that have essentially shown the same thing. Sunitinib is no longer a firm standard of care in the front line for our patients. And Dr. Motzer led the effort to combine PD-1 blockade with CTLA-4 blockade, once again proving superior to sunitinib for metastatic clear cell kidney cancer. One of the biggest questions, so if you were to go to a medical oncology meeting, which you may want to go, you may not want to be there, but at ASCO coming up next month, one of the big debates will be, of all of these approaches, and these are all of the positive pivotal trials that have been seen in the last few years, which regimen should be favored. Most of these regimens on this slide are essentially the same theme, which is VEGF blockade plus PD-1 blockade, except for nivolumab and ipilimumab, which is PD-1 plus CTLA-4. And we spend a lot of time at these meetings trying to determine which one is best for our patients. But I would argue that these are some of the differences, and we could spend some time on this. This was a medical meeting, we would spend some time on this. There are certain advantages of PD-1 and VEGF. For example, the response rates are higher. So if you have a symptomatic patient and need a rapid response, this approach is probably preferred. Whereas the data with PD-1 and CTLA-4 suggests that if you're a responder, many of those responses are durable, like we saw with high-dose IL-2 in the past, which allows the potential for potentially stopping treatment. But to me, the bigger issue is this debate between PD-1 VEGF versus PD-1 CTLA-4. What I try to argue to my colleagues is it's essentially a waste of our time. Why is that? Because for a variety of reasons. One, because cross-trial comparisons, as we all know, are flawed and we shouldn't do them, but that doesn't stop us. Also, as I sort of alluded to, the Nivo-Ipi trial has much more follow-up than these other VEGF PD-1 trials. So follow-up being unequal, it's harder to make comparisons. But also, I think importantly, as a field of medical oncologists, we don't have an agreement on what I would call the hierarchy of endpoints, which is which endpoints are most important for patients. And let me explain what I mean by that. Well, essentially the question is which endpoints should rule. A lot of people in medical oncology believe that early endpoints are most important. And what do I mean by an early endpoint? Well, what I mean by that is endpoints that develop essentially in the first 2 years after starting a treatment. These endpoints are often favored by industry. They help with FDA approval. And they're certainly important for symptomatic patients, as I mentioned before. But ultimately, I think from a patient's point of view, these later endpoints are even more important. And those are, sort of defined as endpoints that happen after 2 years of initiation of treatment. These endpoints are favored by surgeons, like the folks listening in on this lecture. The chance to cut is sort of the chance to cure was the motto I heard when I was in medical school. The only good outcome for a surgery of cancer surgery was complete removal, elimination of the tumor, so the patient didn't have to come back for medical treatment. That's the same endpoint that's favored by our colleagues in the stem cell transplant world, where they focus on these tail of the curve endpoints being ideal. Endpoints like duration of response and landmark progression-free survival and overall survival. But also there's a third class of endpoints, which I would call durable endpoints, which are developed after the treatment stops. And those are most favored by patients, meaning patients don't just want to be alive at 5 years. They would like to be alive and off treatment. And this is a category, a new sort of endpoint we are trying to define for solid tumors called treatment-free survival. And I'll talk about that in a second. So when you start looking at the trends that we've seen with PD-1 VEGF and PD-1 CTLA-4 with more follow-up, the data with PD-1 VEGF is not as strong as it was, at least initially. You see the hazard ratio for overall survival going up with time for the axitinib pembrolizumab combination, whereas the hazard ratio for survival was not as strong initially, but it's maintaining itself, meaning the survival curves are flattening for our patients with PD-1 CTLA-4. And this can be also shown here, looking at progression-free survival for patients receiving PD-1 CTLA-4. You see that tail on the PFS curve. About a third of patients are alive progression-free on that first pivotal trial, whereas we have yet to see a plateau emerge with the axitinib pembrolizumab combination. And essentially, I would look at, sort of which combination is superior. I'm obviously pretty biased, but because of its ability to produce improvements in late and what I'll soon talk about is durable benefits, we favor, at Beth Israel Deaconess, we favor IO combinations as our first initial treatment, but most people, particularly in community settings, will get PD-1 and VEGF. So, we talk about important questions, which regimen should rule. I think actually the work of, this is Dr. Larry Einhorn in testicular cancer. This was a paper he published about 40 years ago, where he argued that testicular cancer was a curable neoplasm. I would like to argue and spend some time talking about how in kidney cancer today, I think we're actually dealing with a cancer that can be cured, maybe obviously not in as high a percentage as testicular cancer now, but maybe closer to what testicular cancer was like 40 years ago, and that we should work as a field to try to increase the remission or increase the cure rate for our patients. So getting back to this question, if you believe, like I do, that kidney cancer can be cured, then it sort of follows that we should work to make cures more common. And when, what is the evidence that cure or remission is possible in metastatic kidney cancer? Well, this is some data that was published last year from that Checkmate 214 Ipi-Nivo study. What you're looking at in blue is patients with getting durable responses off treatment. This is just the patients who had complete responses. Similar data was seen in patients who had partial responses. So there seems to be a connection between depth of tumor shrinkage with immune therapy and ability to live in remission. And we'll obviously have to wait for more data on this subject. I'm not arguing that IO therapy should be applied to every patient. For many years, we've been doing research trying to come up with predictors of response to immune therapies with obviously very mixed success. And this approach is going to be important. I would argue even more important that we work on developing predictive biomarkers so we can just rationally apply these drugs to the patients most likely to benefit, in part because PD-1 blockade is about to come to the adjuvant setting. and we'll talk about that in a second. Here's some of the biomarker work that we've done. This is with colleagues, as shown here, from Genentech, who made a major investment in trying to understand how kidney biology impacts response to treatment in their Emotion 150 and 151 analyses. They did a very comprehensive analysis of the tumor. This was followed up in the phase 3 study. You can see all of the tissue-based work that was done on this cancer cell paper, looking at somatic alterations, PD-L1 staining, clinical risk, sarcomatoid histology. Essentially, everything but tumor mutational burden was associated with greater chance of response to PD-1 blockade in this experiment, both infiltration of T cells, sarcomatoid differentiation, PD-L1 staining. That doesn't mean we're ready to create biomarkers for clinical decision making, but we have a better sense of tumors that are more likely to respond to immune therapy than we used to. And in this work, they were actually able to break kidney cancer down into 7 different subpopulations. Based on RNA sequencing analysis. This was one of the first prospective trials to actually look at this, in not just kidney cancer, but in any cancer, and finding that this T effector infiltrated biology was more likely to respond to immune therapy. And maybe these are the patients that should get immune therapy. And some of these other groups need other approaches like angiogenesis blockade and even new novel therapies. So we're learning a lot about how to target kidney cancer from analysis of kidney tissues. So other ways we can make more cures more common in kidney cancer. One is by rationally applying it to the right patients. The other is to do novel trial designs, bringing therapy up into the front line or even closer. This is the Keynote 564 study. This will be a plenary presentation by my colleague, Dr. Choueiri, at ASCO next weekend, or 2 weekends from now, I should say. This is pembrolizumab versus placebo in stage 3 patients. The press release says this is a positive trial. We obviously need to see the data, but if this data holds up with more scrutiny, it'll likely become an FDA-approved regimen sometime in the next year or so, I would imagine, and this will have great impact on your clinical decision-making when dealing with these patients in the urology clinic. It'll require much more multidisciplinary consultations. This is another preoperative PD-1 blockade approach that's being tested. This is certainly a novel design. When Chuck Drake first approached us about this concept, a lot of the people thought Chuck was crazy. His concept here was taking a patient with localized kidney cancer and giving some of them PD-1 blockade before you take the tumor out, and comparing that to just observation alone, sort of pre-surgical PD-1 blockade. The thought being that the drug in kidney cancer immune therapy is actually the T cells. So let's give PD-1 while we have the highest number of T cells around in the patient to stimulate a response. As I mentioned, that idea was thought to be a little crazy back in the early, maybe 2012, but now it's becoming more established in other tumor types. So we're seeing responses in this neoadjuvant setting in lung cancer. This is the first randomized trial to look at this in lung cancer, showing a difference with preoperative nivolumab in patients with lung cancer on the Checkmate 816 trial. So we'll have to wait to see if this is an approach in kidney cancer for the results of this so-called PROSPER study, but it suggests that even more, we're going to need to working closely, potentially with our surgical colleagues to make decisions about when to give PD-1. Other ways that we can develop more cures in kidney cancer is to develop novel targets. Srinivasan is going to talk about how, some novel targeted therapies. I want to talk about some novel immune therapies, things like vaccines, novel checkpoints. CAR T cells are now being tested in kidney cancer. TIL therapy is also being developed in kidney cancer to hopefully enhance the immune response. What we're doing as a group up in Boston is we're doing single cell sequencing on patient tumors to determine when the best time to apply immune therapy is. So for example, maybe not surprisingly, early stage tumors have far fewer exhausted T cells in them. This is work by David Braun and colleagues. And there's also other inhibitory factors in the tumor that we may be able to target. in future trials. So by doing this latest technology, single cell sequencing of tumors, we're coming up with new targets and new ways of bringing these treatments to the clinic. So for example, they're using sequencing data, both RNA and DNA, to create neoantigen vaccines. This is the work of Kathy Wu's group at Dana-Farber. These are in testing in the adjuvant setting. We're also looking at novel immune checkpoints. This is Gordon Freeman and Rupal Bhatt, who work with us up in Boston. They believe they've identified a new pathway, this so-called HHLA2 KIR3DL3 pathway that's expressed in kidney cancer, and maybe a resistance pathway to PD-1 blockade that they now can drug. In the preclinical setting, they're working on developing antibodies that can be used for human testing. It's obviously a very strong group to be working on that, given Dr. Freeman's track record. In preclinical experiments, when they block this interaction, they can actually improve the anti-tumor immune response. So we'll see if that holds true in human trials. But once again, what we learn from human tissues is hopefully developing new treatments for our patients. And finally, as I mentioned, trying to make cures more common in kidney cancer, we should also focus, I think, on novel endpoints, more surgical endpoints. I want to focus on a new one that we're developing called treatment-free survival. What is treatment-free survival? Well, it's a breakdown of all the time, different ways patients can live after treatment. Here in purple, they can live on protocol treatment. In gray, they can survive on subsequent treatment. But with immune therapy, they can live off treatment in so-called treatment-free survival. And both the good and the negative of immune therapy can last after treatment is stopped. So we measure both treatment-free survival without toxicity and treatment-free survival with toxicity. And it turns out when you do that, not only is overall survival greater with CTLA-4 PD-1 compared to VEGF blockade, but treatment-free survival is twice as long. So patients are not only living longer, they're spending more time off treatment with the approach of ipilimumab and nivolumab. So, and when we talk about creating more treatment-free survival, one potential approach, going back to our testicular cancer colleagues or our lymphoma colleagues, is, should we push for deep responses, much like you do with a testicular cancer patient? So this is a look at the NCCN guidelines for testicular cancer. As you know, when we don't get a good enough response to initial medical therapy, some patients are considered for a more aggressive approach to try to salvage them, to try to create those remissions, which may lead to cures. How can we do that in kidney cancer? Well, one approach that's being tested in melanoma and other tumor types that we hope to test in kidney cancer in the coming year is TIL therapy, where once again, working with our surgical colleagues, this approach was also developed at the surgery branch at the NCI, where you take a surgical specimen out of a patient, harvest the T cells, reinvigorate them, and then give them back to the patient in the setting of IL-2 and chemotherapy. It's obviously very intensive, not for everyone approach. And we don't know if it's going to work in kidney cancer, but the argument would be, can we test it? Should we test it to try to produce more remissions for our patients? So we hope to be doing that next year. And sort of just in summary, I hope I've made the argument to you that we can make cure more common in kidney cancer through novel designs of trials, through novel targets, through novel endpoints, and hopefully through novel algorithms of being more aggressive in patients who are motivated, much like this patient here. This is a patient of ours with metastatic kidney cancer who's living in treatment-free survival following PD-1 blockade, and also trying to shorten his life at the same time by diving off the tallest bungee jumping platform in the world, which seems like a kind of crazy thing to do. But anyway, we want to create more outcomes like this, and hopefully with collaboration with our urologic colleagues, we can do that. And there's a lot more to be explored in the future. Thank you very much for your attention.
Thank you, Dr. McDermott, for a really fabulous talk. It's so exciting to see where we are today, and I really appreciate you also highlighting sort of the critical role, I think, of the urologic surgeon in working with medical oncology, in thinking about neoadjuvant plus adjuvant, And then also together, who knows, these exciting ideas about TIL therapy and all, we'll see. It's so exciting to hear about, and the unbelievable advances y'all have made with the immunotherapies as well as targeted therapies. Wow. Our next speaker is Dr. Prasad Srinivasan. Dr. Srinivasan is going to talk about targeted and other therapies for kidney cancer.
Thank you, Dr. Linehan, for that introduction. And I've really enjoyed the talks that preceded mine today. I'm going to spend the next few minutes building on some of the themes you've already heard. I'll focus on emerging therapeutic strategies, both in clear cell kidney cancer and some non-clear cell kidney cancer variants. Dr. Mcdermott very elegantly showed you over the last few minutes that combinations of VEGF receptor targeting TKIs and checkpoint inhibitors targeting the PD-1 axis, or dual checkpoint inhibitors, have become the mainstay of treatment in patients with newly diagnosed advanced clear cell RCC. As he noted, many of the tools we've had, which belong to one of these two categories, checkpoint inhibitors or VEGF targeted TKIs, have been moving earlier and earlier in the course of the disease as viable and reasonable management strategies. What this does is, it's fantastic for people who have just been diagnosed, but once people progress on these therapies, as most will, we don't have great data telling us how to manage patients following progression on these frontline therapies. Situation is going to get even more complicated with the advent of possibly adjuvant usage of checkpoint inhibitors. It's clear that we're going to need new approaches to treating patients who have exhausted these standard options. To try and look for these options, some of us have gone back to the VHL pathway, which after all has been the basis for most targeted treatment strategies that have been used in patients with clear cell kidney cancer to date. Since the discovery of the VHL gene in the early 90s by Dr. Linehan and his colleagues, we've understood a lot about how loss of that gene leads to kidney cancer. And we've also understood, by understanding this or exploring this pathway better, how hypoxia, or the cell's ability to sense or perceive hypoxia, real or imagined, can lead to kidney cancer, as well as affect various other cellular processes. Work that's led, as Dr. Linehan alluded to, a Nobel Prize in medicine not too long ago. What's further emerged over the years is that HIF2, one of the HIFs that we see upregulated in response to VHL loss, is more likely or more involved in cancer causation in VHL negative tumors. Ideally, we'd be able to target HIF2 alpha rather than downstream consequences, as we've been doing for years now. But HIF2 has been an elusive target for drugs. It's been particularly difficult to target until 4 or 5 years ago, when a group of scientists from industry as well as academia got together and identified a pocket in HIF2 alpha, which they could block with small molecule inhibitors and prevent it from then binding HIF1 beta, and that dimerization being essential for function of this particular molecule. The prototypic molecule PT2385 was very quickly taken into the clinic, and in the context of a phase 1 study with an expansion cohort, activity was easily demonstrated in patients who had been previously heavily treated with metastatic clear cell kidney cancer. The response rates were around 14-15%, with a lot of patients demonstrating stable disease. One problem that became apparent fairly early in the course of studies with this drug was that there were significant pharmacologic limitations to this drug, with a lot of interpatient variability in drug levels and pharmacokinetic processing. When you actually look at patients treated on this initial study and try to separate them out based on the steady state levels of HIF2 alpha and its metabolite, it emerged in this ad hoc analysis that those who had higher steady state levels appeared to do better. To try and circumvent the problems posed by these limitations, a second generation agent called PT2977, also known as MK6482 or belzutifan, the latter name is what I'm going to be using for the rest of my talk, was designed, and again showed very, very promising activity in early phase studies in patients with advanced clear cell kidney cancer, with response rates in the mid-20s, but disease stabilization rates that were much, much, much higher. Most patients who responded or seemed to benefit from this drug also seem to do so for reasonably prolonged periods, as is shown in the swimmer's plot from a presentation Dr. Shwedi gave a few years ago, detailing the data from the study. Most importantly, this class of drugs seems to be very, very well tolerated, with anemia being the most common side effect. So it's easy to use both as a single agent, but also as a combination partner, which you will, I think, hear more and more about as time progresses and new studies are designed. Belzutifan or MK6482 is now the subject of an ongoing phase 3 study in previously treated patients, and the agent is being compared to everolimus in a global randomized study. Results are awaited. It's probably going to take a little longer for us to see what these data show, but I'm very, very excited about the prospect of this drug and actually this class of drugs making a real impact in patients with clear cell kidney cancer. We really made headway in the treatment of patients with advanced clear cell kidney cancer by studying patients with VHL. Have we then been successfully able to apply the treatment principles that we've developed in patients with advanced clear cell kidney cancer to patients with actual VHL-associated tumors? As you know, the current management of VHL hinges heavily on surgical or ablative intervention. And while effective in preventing local symptoms and then minimizing the risk of metastatic disease, it's clear that there is a lot of morbidity associated with these surgical approaches. Most patients require surgical control of their disease, repeated multiple times during their lifetimes, to remove not just kidney tumors, but also pancreatic neuroendocrine tumors, CNS hemangioblastomas, and other lesions. These procedures take a toll on the body. And patients at some point want to avoid surgery at all costs. So we, as a medical oncologist, has worked with urologists for a long, long time. I really begin to appreciate the need for complementary strategies that would help surgeons better manage these patients. We've looked at VEGF-targeted agents in this patient population and found that those agents have modest activity and are associated with what this patient population really is prohibitive toxicity. So there isn't widespread use of these agents because of these limitations. We asked if the HIF2 alpha inhibitors that we've seen such promise in early studies with in advanced clear cell kidney cancer could then be used in patients with VHL-associated tumors. And we conducted a multi-center global study that's been reported in abstract form. 61 patients were enrolled on this study. And when we looked to see what happened to the renal tumors following treatment with these patients, 36% of the patients showed a confirmed response. What's not shown in this table, but what we know is that an additional 11 to 12% of the patients have had a response that is yet to be confirmed at the time of this analysis. HIF2 alpha inhibitors tend to act slowly and continue to act for a long time. So it's not uncommon for patients to start off with stable disease and months later develop complete or partial responses. And it's our expectation that the response rate in these patients is probably going to go up. Most patients seen on this trial had some degree of tumor regression, as is shown here, and responses tended to be very durable, with a median duration of response or median PFS far from being reached on this study at this point. We also look at the changes wrought by this group of agents in this patient population in a different way here. This is a spider plot showing that tumors in patients who were enrolled in the study showed a very distinct, clear pattern of inexorable growth before starting the therapy, but with most patients demonstrating stability or shrinkage of tumors that seems to persist following initiation of therapy. This is an example of the kind of responses we've seen with this drug. This is a patient with bilateral multifocal disease who's undergone prior surgery and is really hoping to avoid further surgery. Came on our study more than 2 years ago with what I show here, 2 renal tumors, one on the right kidney and one on the left kidney, both demonstrating very impressive and sustained response following initiation of therapy. Dr. Linehan told you that VHL affects multiple organs, with tumors very commonly seen in the pancreas and CNS and other organs. So do we have an impact on tumors that arise in organs outside the kidney with this group of agents? And shown here is a glimpse of what we see in extrarenal lesions associated with VHL. Patients who had pancreatic lesions, in this instance, all 61 patients on study had a pancreatic solid tumor. The response rate was around 64%. While in patients with CNS hemangioblastomas, 43 of them, the response rate was 30%. Many of these patients actually had complete resolution of all evidence of disease, around 6% in patients with pancreatic tumors, and around the same 5% or so in patients with CNS hemangioblastomas. CNS hemangioblastomas are a source of significant morbidity in these patients, requiring surgery, and patients often suffer functional issues following surgery or due to these lesions themselves. It's shown here as a young patient who came on study with multiple CNS hemangioblastomas, as indicated by the red arrows, both in the spine and in the cerebellum, showing unequivocal regression following initiation of therapy. We've also seen regression of tumors in the retina. These are, again, very vascular tumors called retinal hemangioblastomas that are typically managed by laser ablation, but there's only so much real estate in the retina, and only so many times you can perform these procedures without actually eventually impairing vision. And this approach is beginning to show early promise in controlling the disease process in the kidney, and hopefully offering an alternative to these surgical or ablative approaches. One key issue with this drug is that it is much better tolerated than the VEGF receptor targeted TKIs, as is shown in this slide. A lot of patients develop side effects, but most are very manageable. Most are very low-grade toxicities, with anemia, which is an expected side effect, as I told you, of this drug, being the most common grade 3 or 4 grade 3 side effect. And when it does occur, it's also very easily amenable to management. These data have led to the FDA considering a new drug application for this agent in patients with VHL. The FDA has granted priority review to this application, and we expect to hear on or before September 15th whether the FDA deems this drug worthy of approval in this patient population. If approved, this is going to provide, in my opinion, a real alternative for the surgical management in this group of patients. I'm going to switch now and spend the next few minutes to outline some management strategies in papillary kidney cancer, which is the second most common form of kidney cancer that we encounter. To date, there are very few effective treatments for treating advanced papillary kidney cancer patients. In the last 6 to 12 months, we have found from Dr. Mcdermott's work that pembrolizumab, a checkpoint inhibitor, does have activity in patients with non-clear cell kidney cancers, including those with papillary RCC, with response rates approaching around 30%. More recently, a randomized phase 2 study that looked at the efficacy of a variety of different MET-targeted TKIs compared to sunitinib demonstrate that one of these agents, a dirty tyrosine kinase inhibitor that also targets MET, cabozantinib, is superior to sunitinib in this group of patients, while the more selective MET inhibitors did not seem to offer any benefit. In this unselected group of patients with all forms of papillary kidney cancer, however, even with cabozantinib, the median PFS was only 9 months and the overall response rate is only 23%. Clearly, we can and should do better. But how do we go about doing that? We know and have known for a long time that papillary kidney cancer is a very diverse group of malignancies. Type 1 papillary RCC appears, at least in some cases, to be driven by MET. And type 2, an old designation, which I like to call non-type 1 because it's a very heterogeneous group of malignancies characterized by very distinct histologic subtypes as well as distinct genetic alterations. It's characterized by many, many different alterations, some of which at least are amenable to targeting. I'm of the strong belief that by really understanding the basis of these individual forms of papillary kidney cancer, we're going to be better able to target these subtypes of this variant and really make an impact on the management of patients with papillary kidney cancer. I'm going to skip a couple of slides in the interest of time and move to some studies we did in the early part of this decade with MET inhibitors, studies that were driven by the finding that a subset of patients with papillary kidney cancer, those with a hereditary condition called HPRC, had activating germline MET mutations. MET mutations are also seen in sporadic forms of papillary kidney cancer, but only in a small minority, around 15 to 20% at the most. A lot of patients with papillary kidney cancer, however, have amplification of chromosome 7, which is where both MET and its ligand HGF are located, leading a lot of us to postulate that that may be another mechanism by which MET drives these tumors. I don't believe at this point that that's entirely correct. I certainly don't believe that chromosome 7 amplification by itself makes a tumor MET driven. And this is what we showed very early in 2013 with foretinib, a MET inhibitor, where we showed there are 67 patients who were treated with this drug. If you had a germline alteration in MET, you had a 50% probability of having a partial response, with most of the others demonstrating very meaningful stable disease, meaningful shrinkage of tumors that just didn't amount to a partial response. On the other hand, if you just had a gain of chromosome 7, your response rate was very, very modest, 5 to 10% at best. This is further exemplified in this graph, which really represents tumors from all 10 patients who had germline MET mutations, demonstrating that each single tumor in those patients had some tumor regression, providing proof of principle that if you have a MET mutation, MET inhibitors do seem to be effective. However, as we've seen from multiple studies, if you don't have a MET mutation, only a minority of patients seems to benefit long-term. Another subtype of papillary kidney cancer where we seem to have made some headway is HLRCC, or hereditary leiomyomatosis in renal cell cancer, that Dr. Linehan described in some detail in his talk. I'm going to skip a few slides and tell you a little bit about a study we conducted here at the NCI, looking at the combination of bevacizumab and erlotinib, a combination that was designed specifically to target metabolic consequences of fumarate hydratase loss in this group of tumors. This study enrolled both patients with HLRCC and patients with sporadic papillary RCC. Total of 83 patients, 43 in the HLRCC group and 40 in the sporadic group were enrolled on the study. And the results are summarized here. In the HLRCC population, the overall response rate was 72%, with 31 of 43 patients demonstrating a partial, a clear response, including 2 patients who had a complete response. Most patients treated had some degree of tumor regression, And patients who did respond tended to do so durably, with several patients staying on therapy for 4 years plus. The median PFS was a respectable 21 months. In patients with, I'm going to skip a couple of slides again as we're coming to the end of my talk. In patients with sporadic papillary RCC, we also saw responses. But in keeping with the theme that when you have a therapy that targets a very specific population, you're more likely to see higher responses with the response rates and efficacy going down when you look at a more diverse population. We see that the overall response rate in this relatively unselected sporadic patient population with papillary RCC was a little lower, 35%. We still saw a lot of patients enjoying stable disease, a lot of patients demonstrating tumor regression, and a lot of patients, especially those who responded, demonstrating durability of response, very, very similar to what we saw in patients with HLRCC. One of the areas that we're exploring actively at this point in my group is trying to understand who these patients are in the sporadic papillary population that appear to respond so well and do so in a manner that's very, very similar to that of the HLRCC patients. I'm going to stop there in the interest of time. What I've hopefully shown you in the last few minutes is that there are a lot of new pathways being pursued to complement the strategies that have already been effective in patients with advanced clear cell kidney cancer, especially strategies targeting the HIF2 pathway. And I hope I've also shown you that while we have a long distance to go in treating patients with papillary kidney cancer, by picking the right patients, identifying suitable targets in those patients, and matching them with the appropriate targeted agents, we can make a lot more headway than we have been able to hitherto by treating papillary kidney cancer patients as one entity, because they simply are not, as we've learned time and again over the last 15 to 20 years. I'm going to stop there and allow some time for the group to answer questions. Thank you all for your attention.
Thank you, Dr. Srinivasan, for really exciting talk. And I know I've learned a huge amount. I also want to just mention to our audience, who are primarily urologic surgeons, just remind you a little bit what we've seen. We've heard exciting things about treatment of advanced kidney cancer, of course. But we've also heard a potentially important role for you to think about in neoadjuvant, in other words, before you do surgery. So we'll think about that. And also in the adjuvant setting, it looks like there's some exciting things coming up there as well. But the other thing that you heard about was small renal masses responding dramatically to therapy. Dr. Srinivasan showed you clear cell tumors, a huge percentage of those getting smaller on therapy. And he also showed you papillary kidney cancers with a certain mutation, MET mutation, getting dramatically smaller on therapy. Now, that's a little bit new to us. So another thing that is in our future to think about, we're not there yet, these drugs need to get approved and all that stuff, but we may be thinking differently about how we manage small renal masses. Is there a role for therapy for those? Or you heard very elegantly from Dr. Ball about complex surgeries. Let's just say we had a tough partial with a big lesion. We wanted to save that patient's kidney. Will it make sense to give systemic therapy then to make it easier to do a partial? So we'll see together. It's too early to know the answer to those things, but there's some very exciting things to think about now. That's, it's different than than we would have thought of. Dr. Ball, I've got a question here that came up from one of our colleagues here, and that is the following. Very good question. I know keep some people up at night, but other people less. And that is, the person asked the following. You gave very elegant discussion about enucleation, about partial refractory margin. What does the doctor do, the urologic surgeon do? What does he or she think about? They do a partial and they have a positive margin.
Yeah, great question, and one that we discuss at meetings and is addressed in the literature sometimes. But so a few different ways to think about that. How do we get a surgical margin, a positive surgical margin? Well, I showed you a diagram of tumor enucleation. Sometimes, if the pathologist does not see normal renal parenchyma and there's tumor up to the edge, even though there's a pseudocapsule, that could be called a positive margin. And speaking with colleagues in other institutions, that is sometimes a barrier to doing tumor enucleation, the fear of being called a false positive margin. Other times, the margin can be because there's either micro or even macroscopic disease that's left behind. So how do you differentiate between those three? I think really the key is your post-op imaging. If on post-op imaging, there is no disease seen, I don't think it warrants doing anything until you see disease. Sometimes the question comes, there's a positive surgical margin, do I need to do a completion radical nephrectomy? I think usually no. There may be some cases. Maybe it's a really aggressive tumor. Maybe it's an HLRTC tumor, like Dr. Linehan described. Maybe it's a Furman grade 4 clear cell with sarcomatoid features. But for most cases, I think that close surveillance with cross-sectional imaging will determine which way to go.
So, Dr. Mcdermott, thanks again for an elegant, really inspiring talk. Wow. Just cut to the chase here. 2 patients. One comes to you with a metastatic clear cell, and another comes, we'll say, non-clear cell. I don't know. We'll say papillary metastatic. What do you start with in both cases? IO therapy, and if so, what IO therapy?
Well, we have an IO bias, as was obvious in my talk. But so if the patient is asymptomatic, we favor, for the clear cell patient, IO combinations of PD-1 and CTLA-4 because of the data that suggests that there's a tail on those survival and progression-free survival curves. Knowing that if the patient fails to respond, you can move to a VEGF targeted strategy after that. That said, in the community, most of those people are getting treated with the PD-1 VEGF combinations in many centers, in large part because those combinations are somewhat easier to manage from a toxicity point of view. There's less IO toxicity when you leave out CTLA-4. For non-clear cell patients, there's no, as Ram mentioned, there's no approved regimen for that group of patients. But early data suggests that IO agents are more active there than we would have expected. So the old paradigm in the cytokine era was that cytokine therapies don't work for most patients. They work even less well for non-clear cell patients, so we shouldn't do them. So we don't have as much data because non-clear cell patients were excluded from the initial trials, but subsequent trials suggest that IO approaches are applicable. They're not specifically approved there, but you can use them sort of based on the data from the clear cell approach. But to Ram's point, I think we need much more understanding and much more targeted approaches to those diseases, because as you pointed out, Marston, we're probably dealing with 8 or 10 different, cancers in that non-clear cell bucket, many of which are never going to respond to IO therapy. So for example, the data for chromophobe kidney cancer is far less good than papillary. So it's these sort of intricacies that you have to take into account when deciding what to do. But there's more options now than there were a couple of years ago, and that's important.
Okay, I think we have time for one more question before we go to the post-test. Dr. Srinivasan, beautiful talk, my word. Targeting these genes is just unbelievable to me. Let me ask you a question. So a patient comes to me, I'm a urologic surgeon, and I got a pretty big tumor, and I do a nephrectomy maybe or something, and it's a big, anyway, patient's doing fine, but then now I'm 6-8 months later, And I now, I do a chest CT, and I've got 2 or 3 small lesions, okay? And maybe let's say it's clear cell. I got 2 or 3 small lesions. Now, I'm going to, of course, talk to my medical oncologist, which of course will be you. But what, how do you think about these? Is there a role, do you think, for quote active surveillance kind of? In other words, do we need to treat every? I mean, will our medical oncologists want to treat everybody, or might they kind of watch things a little bit? How do you think about those?
I think it's a fantastic question, and it's a situation I think we face fairly commonly in the clinic. And I think if you talk to multiple oncologists, you're going to find a wide array of opinions. And as with choice of frontline therapy, you're going to see slightly different patterns of practice in the community versus what you see in academic centers. My own bias is that the decision needs to be individualized to each patient. So I look at factors like, what's the bulk of disease? Do we have a sense of the pace of disease? And if so, if the time to recurrence has been long, if the pace of disease appears to be slow, if the disease volume is small, the patient is asymptomatic, I tend to offer a lot of these patients surveillance because we know, despite the advances we've made with immunotherapy, the vast majority of patients we're not going to cure. Vast majority of patients are going to have side effects. And I, in my practice, I've tended to delay the time at which we expose these patients to these side effects.
Okay.
Another factor also is sometimes when you follow these patients long enough, they don't have additional lesions come up. You can actually subject them to curative or resection with curative intent. So that's another reason we tend to follow some of these patients in my clinic.
Thank you very much. I think that's really helpful to know that. I mean, to really think that, no, that's going to be an option going forward. So again, really like to thank you for being with us this morning, for joining us for diagnosis and management of localized, locally advanced kidney cancer, presented by the AUA, and very, very, very much appreciate Dr. Ball, Dr. McDermott, Dr. Srinivasan for taking the time to be with us, and more importantly than that, for doing the great work that you're doing to help our patients with kidney cancer. Makes a big difference, and it's just amazing how exciting things are and how much progress has been made in dealing with this disease, both from a surgical point of view, incredible, as well as a therapeutic point of view for a cancer that when we started our work, for sure, many people thought was just untreatable. And I agree with what Dr. McDermott and everyone has said. We're working to cure all patients with this disease. That's why we're here. That's what we do. Anyway, thank you all. Really, really loved hearing your talks and learned an enormous amount myself. If our audience learned as much as I have, for example, it was a great session. Thank you all very much.